Move on to the next topic, which will be taken by Dr. Professor PC Manoria, who is the Director of Manoria Heart and Critical Care Hospital, Bhopal. He is the honorary cardiologist of His Excellency, the Governor of MP. He's a past professor in HOD, Gandhi Medical College, Bhopal, past chairman, Hypertension Council, APSC, past vice president, SARC Cardiac Society, past national president, API, CSI, ICC, ISC, ISCPT, GSI, ISEM, IFUMB, HSI, etc. He's a past dean, Indian College of Physician and Indian College of Medical Ultrasound, and past editor-in-chief, Journal of Nuclear Cardiology Society of India. And he'll be speaking on a very important topic, that is the role of RAAS blockade in primary and secondary prevention of coronary artery disease, and how ACE inhibitors are different from ARBs and which one is superior. I think Dr. Manoria will elaborate on this point. Over to you, sir.
Are the slides visible?
Yes, sir.
Yes.
Okay.
Yes, sir.
So for the next 20 minutes, I will be talking on RAAS blockers in primary and secondary prevention and are ARBs equivalent to ACEI inhibitors. All of us know cardiovascular disease is multifaceted, but RAAS stimulation plays a central role in the pathogenesis, and therefore RAAS blockage is a logical therapeutic approach. Now, when we look at the issue of ACE inhibitors versus ARBs in hypertension, let's have a look. You have already seen that the diagnosis of blood pressure may be different with different guidelines, as you can see with ESC, 140/90, ACC, 130/80, ISH, 130/85, but all guidelines are unanimous that the target should be 130/80 or less. Now, if we look at this meta-analysis, you can see most of the landmark trials have been included. If you look at the ACC, angiotensin converting enzyme inhibitor on the left, you have the ALERT trial, you have the ANP-BP2 trial, ASCOT, BPLA, high-weight, advanced. And if you look at the right side, the meta-analysis has included most of the ARB trials, the renal, the INT, life, scope, value, and so on. Now, when we look at the results of these meta-analysis, is there a difference? You can see very clearly on the left side of the screen that ACE inhibitors are associated with a statistically significant 10% reduction in the all-cause mortality, whereas there is no significant mortality reduction with ARB. It is only 0.01%, 1%, clearly indicating ACE inhibitors decreases mortality, but ARB failed to decrease it. Now, when we look at the issue of diabetes, you can see this is a new meta-analysis. If you compare ACE inhibitors with ARB, the all-cause mortality is decreased by 13%, which is significant. For ARB, it is -6, which is not significant. CV mortality decreased by 17%, and with ARB, this is increased by 21%, which is very, very distressing. Cardiovascular event decreased by -14 with ACEI, whereas decreased by 6%, which is not significant. Myocardial infarction, ACE inhibitors decreased by 21%, and they were only decreased by 11%. Heart failure, 19 and 30%, and stroke, again, less than 5%, but there was no change in the stroke with ARB, indicating that ACEI has advantages over ARB. Now, this is in another meta-analysis, and you can see that ACE inhibitors significantly reduces the risk of all-cause mortality by 13%, CV mortality by 17%, major CV events by 14%, including myocardial infarction by 21%, and heart failure by 19%. But when we look at the data of ARB, you can see there's no significant reduction in the all-cause mortality, CV death, or major CV events. If you have diabetes with hypertension, what is the issue? Now, this is the PRISMA compliant systemic review and meta-analysis. And again, this was carried out for trials of 16 years from 2000 to 2016. And you can see the change in the all-cause mortality on the left lower panel and the change in the CV mortality on the lower right panel. And if you look at the data, treatment with ACE inhibitors is associated with significant reduction in all-cause mortality, 13%, which is significant. P is 0.008. And the CV mortality is again decreased. The P value is only 0.03. CV mortality was decreased by 19%. But with ARBs, there's no significant decrease in the occurrence of all-cause mortality or with the cardiovascular death. And when we look at the secondary endpoint, you can see with ACE inhibitors, MI, stroke, heart failure, CV events, all are decreased. You can see all the values are significant, but with ARB, all the values are not significant. The P value is more than 0.05, indicating ACE inhibitors has an edge over ARBs in diabetics. And this is the conclusion which we have already talked. But when the question comes of CAD, there is a red signal, and all of us know about the ARB-MI paradox. And look at this. MI increased by 54% in the IDNT, CHARM 52%, value 19%, I preserve 11%, and so on. But when you look at the ACE inhibitors, HOPE trial decreased by 20%, and the Europa trial 22%. So there is a great paradox. MI are increased with ARBs, and ACE inhibitors decreases MI. What is very curious is that longer is the duration of ACE inhibitor, more is the decrease in MI. You can see beautifully on this side from consensus, area, trace, salt, treatment, prevention, and save. As the duration of the trial decreases, the magnitude of the benefit decreases. And this is again a comparison. You can see if you look at the ARB data, global death increased by 1%, CV death increased by 1%, stroke decreased by 8%, MI increased by 8%. But if you look at the ACE inhibitors, the picture is totally reversed. All-cause mortality 9% decrease, CV death 12%, stroke 6%, and MI decreased by 14%. What about CAD patient without heart failure or LVD? This is a very interesting subset. And the HOPE trial beautifully answered this issue. This was a mega trial of nearly 9,700 patients. Age was 55 years. And the inclusion criteria was patient should have a vascular disease with history of either coronary artery disease, stroke, or peripheral vascular disease, or he should be a diabetic with at least one of the other CV risk factors, which may be hypertension. So diabetes with hypertension will come, elevated total cholesterol, lower HDL, cigarette smoking, or documented myocardial. And you can see the benefit at the lower part of the slide. Myocardial infarction and stroke and death decreased by 22% in patients who has vascular disease or diabetes with risk factors without any LV dysfunction, without any heart failure. CV mortality 26%, MI 20%, stroke 32%, and look at the revascularization rates, minus 15%, complication related to diabetes 16%, and heart failure. So what is the issue? Now this trial came into existence when it was seen that data from the SAVE trial, data from the SALT trial was showing decrease in the incidence of MI, and experimental data also shows that increased levels of angiotensins are associated with increased MI, and decreased angiotensin II levels were associated with decreased MI, and this was the reason why HOPE trial came into existence. So the significance of HOPE trial is that if you have patients of diabetes with risk factor which I have enumerated, or you have a CAD, even without blood pressure, or any vascular disease, macrovascular disease with normal LV function, this can be benefited by ACE inhibitors. And The reason why ACE inhibitors, coronary artery disease or even atherosclerotic cardiovascular disease, all the three territories, stabilizes plaque, as we'll see, reduces vessel wall inflammation, and also has a fibrillatory effect. And why and how does ACE inhibitors prevent diabetes and improve glycemic control? There are several hypotheses, but it is sure that they decrease new onset diabetes by 30% or so in various trials. Now, this is another meta-analysis of ACE inhibitors, again in the same subset, CAD without HF, without LV dysfunction. Again, you can see all-cause mortality decreased by 14%, cardiovascular death 19%, myocardial infarction 18%, stroke 23%, cardiac arrest 42%, revascularization 8%, and HF hospitalization 24%. So again, great benefits in this subset. And this is another meta-analysis. You can see the results. Again, all-cause mortality decrease, CV mortality and MI decrease. But when you look at the ARBs, it's not significant. What about the heart failure, which we commonly see? Here again, ACE inhibitors are often preferred over ARBs because of greater evidence in support of their effectiveness. ARBs should only be used if the patient is not able to tolerate. When we look at the ESC guidelines, you can see they recommend ACE inhibitors right on the top, and you can use other drugs, beta blockers, MRAs, and other drugs. When you look at the ESC chart, again, you can see therapy with ACE inhibitors and beta blockers right at the top. They do not mention ARB. If you look at the American guidelines, they recommend all three. You can use an ACE inhibitor, you can use an ARB, or you can use even hardly right from the word go as a class 1 recommendation. Now, what about CKD, which we commonly see in diabetics? RAAS blockers has to be used in patients with CKD because they slow down the trajectory of CKD and postpones dialysis. And when we look at the CKD, there's a lot of excitement in the present state of time. Beside ACE inhibitors or ARBs, SGLT2 inhibitors further slow down the trajectory of CKD, and you can also use other antihypertensives, but these two agents are two revolutionary drugs which slow down the progress of CKD. And we have the third agent, non-steroidal MRAs, which is also shown positive results. And the difference between this is that the RAAS blockers and the SGLT2 benefit CKD by a hemodynamic approach, they decrease intraglomerular pressure. By the non-steroidal MRAs, they decrease fibrosis and inflammation, and therefore they are used in other subset of CKD. STEMI again is a common problem we face. Again, look at the guidelines. The top one is the ESC guidelines, and you can see it begins with ACE inhibitors are recommended starting within the first 24 hours, patient with heart failure, LV systolic dysfunction, diabetes, or an anterior infarct. ARB if patient is intolerant. And the ACC also, again, start with ACE inhibitors, and ARBs only with intolerance to. What about NSTEMI? And STEMI, again, you can see ACE inhibitors, ARBs will come if the patient is not able to. Now, stroke prevention, this is the BPLTC meta-analysis, which shows when ACE inhibitors and ARB are compared in the context of stroke, you see both are in the midline, but CIT, you can see ACE inhibitors is beneficial, whereas ARBs are not beneficial. Now let's look at the meta-analysis which have been conducted on various parameters. Now this is another meta-analysis which shows that when we are looking at the mortality reduction, what if you are treating hypertension with the dark blue, ACE inhibitors are beneficial when compared to if you are treating a diabetic patient, ACE inhibitors are definitely superior. The mortality is increased with ARBs. And CAD, again, you can see ACE inhibitors decreases mortality, ARBs increases mortality, and high-risk patient, again, ACE inhibitors are useful, ARBs just near the midline. If you look at this, another meta-analysis, Bangalore et al., 9 to 11% risk reduction in all-cause mortality, 10 to 70% reduction in cardiovascular mortality, 17 to 19% reduction in MI. So again, telling you ACE inhibitor is better. Now, why this difference between ACE inhibitors and ARB? Now, ACE inhibitors, all of us know, they act by decreasing angiotensin II levels. But when we use ARBs, the angiotensin II levels are increased. It blocks the ATP1 receptors, which no doubt is beneficial. But it also stimulates the AT2, the AT3, the AT4. And now we know stimulation of the AT2 receptors produces hypertrophy, remodeling, brake stabilization, increased inflammation. AT3 produces endothelial dysfunction, it's prothrombotic, and AT4 increases pi release, which we know is detrimental. In addition, the ACE inhibitors inhibits beta-proteinases, which results in stabilization of plaque. If you have more metalloproteinases, they produce unstable plaques. And when we look at the pi1 level, you can see ACE inhibitors decreases pi1 levels compared to ARBs, and as time passes on, ACE inhibitors may even increase pi1 levels. So in atherosclerosis, all of us know there is endothelial dysfunction, and because of this, there is increase in the local mediators like pi1, which produces thrombosis. There's increase in the VCAM, ICAM, and cytokines producing inflammation. There's also an increase in the endothelins. The plaque ACE is increased, which produces decreased bradykinin and nitrous oxide, which produces vasoconstriction, vascular region remodeling, and increase in the angiotensin produces increased proteolysis and even contribute to plaque rupture. When we use ramipril, these local mediators are decreased, the plaque ACE is decreased, and this produces beneficial effects on atherosclerosis, and there's reduction in the clinical events. So in summary, the clinical evidence suggests that ACE inhibitors in ARB have a divergent CV effects on CV mortality and MI in high-risk patients. ACE inhibitors reduces the risk of MI and mortality in high-risk hypertensive patients as well as in diabetics, the elderly, those with vascular disease, and ARBs in contrast have not shown to reduce the risk of MI or death in clinical trials. And systemic reviews and further confirms ARBs lack the cardiovascular protective effects of NV, and you have several publications emerging on the divergent cardiovascular outcomes with ACEI and ARBs, as you can see on the slide. Thank you very much for your kind attention.
I think, thank you, Dr. Manoria, for a very detailed presentation and showing how ACE inhibitors are better among the RAAS blockade, particularly in post-MI substates and patients with LV dysfunction. So my question is, suppose the patient comes with isolated hypertension without diabetes, without coronary artery disease, and without LV dysfunction. So would you prefer ARB or ACE inhibitor in this patient?
I think one of the reasons for using ACE inhibitors is that the all-cause mortality is decreased only by ACE inhibitors. You could argue that ARBs are more potent antihypertensive drugs. The use of ARB is also very high. But what we should do in our clinical practice, suppose you are treating a patient of hypertension, if your targets are not reached, suppose your target is 130/80, your blood pressure is 140/90, instead of using an ARB, you can add another drug to ACE inhibitors and achieve the target goal, so that you will have the pleiotropic effects of ACE inhibitors also. At the same time, you will also achieve the target. So that should be the strategy which should be used. So you get both the benefit, the target BP control and the pleiotropic effects also achieved.
You will be preferring ACE inhibitor of ARBs in patients with hypertension.
The reason I've told you, all meta-analysis show all-cause mortality. That's the only reason for using in uncomplicated, that all-cause mortality is decreased. The magnitude of fall will always be higher with ARBs.
Then what is the role of ARBs in the current era?
See, the conception still prevails, and it is correct to the, from the point of view of stroke prevention, the greater is the reduction in blood pressure, greater is the stroke reduction. That's why we say lower is better for stroke, provided you don't have any coronary artery disease. And that is the reason why people use it. But if you use an ACE inhibitors with add-on drug like calcium channel blockers, you will be achieving the dual benefits. So that is the strategy which is being projected now.
I was going through one of the sales of the pharma companies, and they were I came to know that number one antihypertensive is telmisartan.
Right.
ARBs are the number one selling drug for hypertension, much ahead of ACE inhibitors.
That
Globally, not over India, globally.
Yes, that is very true.
Having said that and done, having said everything, but still, if you look at the practicality, they are still the number one antihypertensive to be prescribed.
It is agreed, and it is a reality.
For various reasons, because it is a very potent antihypertensive. There are no side effects, as cough is one of the major limiting side effects of ACE inhibitors, which do happen in almost 10% of the cases. And ARBs, because of they are weak antihypertensive. Do you agree this or not? ACE inhibitors are weak antihypertensive when used in isolation.
ACE inhibitors are certainly weaker. There's no doubt. What we are interested is to change the outcome of patient of a hypertension. We are not increasing in the numbers. We are interested in the numbers, but there's much more behind the numbers. Our aim is to control the numbers by A plus B or A plus B plus C, and also to utilize drugs in this combination, which also improve the outcome. You've seen MI increase tremendously. ACE inhibitors decrease MI, and I have shown you so much data that ACE. So the approach should be, you use ACE inhibitor, you use calcium channel blockers, you can use other combination drugs and try to achieve the goal, and also have the added advantage of the pleiotropic effects of ACE inhibitors, which are now beautifully tuned. And many guidelines in STEMI, non-STEMI, heart failure, they begin with ACE inhibitors. Hypertension, the guidelines do not differentiate between ACE inhibitor and AR, but with this data that if you only reason for choosing ACE inhibitors and hypertension isolated is they decrease all-cause mortality.
Dr. Vinay is asking, I am starting Remipir is a short-acting drug, does not reduce blood pressure much more. What to do now?
Add calcium channel blocker.
Amlodipine
and have, if it does not add the third drug.
Sir, I wanted to ask you that we see a good number of patients who are elderly diabetics and whose blood pressure is just like 180, 60, 180, 50. They have an isolated systolic hypertension. How will you treat them?
See, this is a common problem. If the patient does not have a coronary artery disease, there is no drug which decreases only systolic blood pressure. You will have a fall in diastolic, and this is the classical. If you don't have coronary disease, you lower systolic pressure as far as possible as the patient tolerates. Don't worry about the diastolic pressure. You should worry will only come if you have a coronary artery disease, prior MI. It will not affect the hemodynamics. Only when coronary artery disease comes, if you are thinking of a drug which decrease only systolic and not, I think we don't have any drug at the present stage. And the preference, of course, is a calcium channel blocker and diuretics, because that will combat the vascular stiffness and also the low renin hypertension, which is rampant in the elderly. So that is the strategy which we follow.
If you look at the HOPE trial, so according to HOPE trial, all patients of diabetes with coronary artery disease with a normal LV function, with a normal blood pressure, should be given a Ramipil. Do you agree with the statement or not?
I think the message from the HOPE trial was vascular disease, atherosclerotic, or diabetes with respect to benefit tremendously.
Even in the presence of normal blood pressure without with normal LV function.
The usual notion is that if you don't have an LV dysfunction, ACE inhibitors may not be beneficial in atherosclerotic cardiovascular disease.
And there's normal blood pressure also.
Yes. People perhaps think that the benefit is because of improvement in the LV dysfunction, but it also decreases atherosclerosis, as has been shown in accident. That was the reason why HOPE trial came into existence. The experimental data showed that if your angiotensin 2 is decreased, atherosclerosis becomes less. The SOLVE and the SAFE showed that MI were less and less, and that was the reason why a HOPE trial was initiated. Somehow this notion has not percolated, and the usual practice pattern is, if you don't have LV dysfunction, don't use ACE inhibitors. It may not be beneficial. Diabetic with hypertensive, I think you have to use whether your LV function is there or not, but the notion still prevails that they may not. But I think diabetic with it is compulsory to use ACE inhibitors. Other it should also be used, but it is not yet percolated in general practice. Many people don't use it.
Sir, one more question. Now, if you have a patient who is diabetic but has no albuminuria, giving them RAAS blockade will help reduce the chances of developing kidney disease, or because now recent data shows that they have beneficial effects only in those diabetic patients who have albuminuria.
Now that is true, but don't forget we have very good data. As hyperglycemia increases, RAAS activity progressively increases. Sometimes I told you. So that is, if you are hyperglycemia, RAAS activity will go on increasing. So that is, you may not get immediate benefit if there's no albuminuria, but in the long term you will get benefit. And once you have RAAS activity, I think all this is a matter of time. Gradually, all these things will come on to the patient. So if you are a diabetic, it is always, they will also decrease the favorable effect on the insulin sensitivity and so many, they will have a favorable effect on atherosclerosis, which is rampant in diabetes and very difficult to control in an aggressive manner. So that is one of the, even the, if you look at the angiotensin in the kidney biopsies, the levels of angiotensins are increased in the kidney biopsy, and this is directly proportional as hyperglycemia increases. But the guidelines will only tell you unless studies are done. So studies only show the benefit is there if there's microalbuminuria or even macroalbuminuria. Studies will not tell you, but we have very good data on this.
Sir, what has happened is that now diabetic kidney disease is now divided into two categories. One is albuminuric diabetic kidney disease and non-albuminuric diabetic kidney disease. And now they have found out that almost 40 to 50% of diabetic kidney disease patients have non-albuminuric kidney disease. So then came the question that whether we should prescribe RAAS inhibition for both the categories or only in one category. So they said that
if you look, this is a statement perfect from the basis of trials. We don't have any data. Now, if you ask whether SGLT2 inhibitors would also benefit patients who don't have albuminuria, the consensus is they will benefit. Now, if this be the state of affairs that you don't have albuminuria and you have CKD, I think the choice would fall on a non-steroidal MRA, which decreases inflammation and fibrosis, and are likely to be more beneficial in interstitial kidney disease, where albuminuria may not be the dominant feature. But because we don't have larger trials or trials, albuminuria, and most of the trials which have been carried are with albuminuria, the benefit is there. But I think because these drugs are very well tolerated, they have benefit not only in the kidneys, they have definite atherosclerosis benefit, and they have benefit in several others. The glycemic control is better. The other benefits, I think, even if you use, although we don't have recommendation from the guideline that if you have a no albuminuria, they would benefit. But the logic seems to say that they may be beneficial.
I think with this, we can conclude this session. I think it was a very interesting discussion on both the topics. I think all the delegates must have learned something from the talks of both the eminent speakers. Now I hand over the mic to Mr. Gaurav from Aventis to conclude the session.
Yeah, thanks a lot, sir. So on the behalf of Sanofi, I really thank our speakers, Dr. Sushil Jindal sir, for a very nice presentation. And also I thank Dr. PC Manoria sir for a very nice presentation about the primary and secondary prevention. And I also thank Dr. Pankaj Manoria sir for chairing the session and setting the context. And I thank all the delegates who have taken out their valuable time on this working day evening for making this program a successful one. So thanks a lot, sir. Thanks for your valuable presence. And I wish you a great evening, sir.